A very good evening to all of you. I welcome you all for this third session of Autism SIG. And like in the last 2 weeks, we'll be having a guest lecture followed by two interesting case presentations. I request our President Dr. Shaban Guldi ma'am, who is the speaker for today, the expert for today's session, and the moderator for today's session. Over to you, ma'am.
Yeah, I welcome you all. And continuing with autism, the most important challenge we as pediatric neurologists face when we have complex behaviors in these children, and we have a very brilliant uh, professional who will be talking about that. And I really, Dr. Vikram Dua has kindly accepted the request to talk on this topic, which is very, very important. And because of which, the problem is it is coming in day-to-day scenario, and then you keep on adding one drug, second drug, third drug. So it is very, very important. And I think the most important thing, which is there for challenging behavior in these children with complex issues. Dr. Vikram Dua is consultant, Queen Alexandra Center for Children, Victoria in British Columbia, medical director, treatment research and education for autism and developmental disorders, Surrey Place, Toronto, and is assistant professor in Department of Psychiatry, University of Toronto. He's executive director of the Indo-Canadian Autism Network, which he has been leading and pioneering, and we are all members of the same network and have a long association with him for the same. And he's founding medical director of BCAN and former psychiatrist-in-chief of Surrey Place and clinical director, clinical assistant professor in the Department of Psychiatry in the University of British Columbia. And going on with the previous plan of having different different researchers and different experts from various resource settings. So we have Dr. Tuba Rashid Khan, who has kindly agreed to come again in this session, who's a pediatric neurologist at the prestigious Autism Spectrum Center at the Boston Children's Hospital. And she's the recipient of the Futures in Neurology Research Award by the American Academy of Neurology and the esteemed A.B. Baker Teacher Recognition Award and the Palutucia Advocate by AN, and author of the inspiring children's book, My Friend Adam. We welcome two more friends today, Dr. Iram Javed, who is assistant professor and head of Department of Pediatric Neurology, Children's Hospital and Institute of Child Health, Faisalabad, Pakistan. And she is interested in pediatric neurology and child epilepsy and neurometabolic disorders. And she's member of CNA, AUCNA, and member of the Child Neurology Society, Pakistan, and the Pakistan Association Neurology Expert Group. And continuing with our friends from Turkey, we are again joined now this time with Dr. Sezin, who's a professor at University Faculty of Medicine, Children and Adolescent Psychiatry Department. And her area of interest are neurodevelopmental disorders and especially autism spectrum disorders, social cognitive disabilities, early diagnosis, clinical symptoms, accompanying psychiatric conditions, adolescence and adulthood characteristics. And she has multiple publications and has completed 9 scientific research projects and 9 research awards by national professional associations. And the other expert, Brigadier K.S. Rana, who is former professor and head of pediatric neurology at Army Hospital. He may not be able to join because of some family issues, or he may join later on. And besides this, we will also be joined by Dr. John Vidyasagar, who is a dear friend and a psychiatrist in NIMHANS, and Dr. Veena Kalra, Professor Veena Kalra, who has been my mentor and guide. She's also there as an expert. And the moderator for today's session is going to be Dr. Mary Ibe, who's professor and head of Department Pediatric Neurology, Government Medical College, Trivandrum, and regional director and visiting professor, Institute of Communicative Cognitive Sciences. And she has innumerable awards and is holding various positions in various child neurology fora. And we'll have the discussion by the talk by Dr. Vikram Dua, and then we'll be having 2 cases by early career professionals. And handing over to you, Dr. Mary.
Evening, sorry. Today we have a very important sort of autism and especially children and their complex nature. We have none other than Dr. Vikram Dua to enlighten us on this topic. Over to you, Dr. Vikram.
Thank you. Can everybody hear me okay?
Perfect.
Yeah. Perfect. Okay. Well, it's a humbling experience to be before this very international and eclectic set of experts. It's been a while since I had such a diverse range. I hope that the information I have resonates. It's always challenging when we're coming from different cultures and different social medical systems, making sense of what is important and not. But what I'm going to talk about today is children with autism growing up. I'm a child psychiatrist by training and worked in autism for most of my career. But in the last, I would say, 2 or 3 or 4 or 5 years have started to shift a little bit and move towards seeing my children grow up and adults. And so I've gotten more interested in longer term outcomes for our children and for our youth. And I'm going to be talking a little bit about some of the concerns and some of the issues that we have in terms of that today. So let me pull up my slides. Okay, so to start, I'm going to start with just what the pathway is for many kids who are on the spectrum. And I like this study. It's a bit dated and it's from the United States, not that dated, from the United States. But I think it illustrates a very important point. And what this set of graphs does, what the study did is that they followed about 250 youth from 4 years before they graduated from high school till 4 years after they graduated to high school. Why they use that as a demarcation point is because the types of interventions and resources and supports changes dramatically once someone leaves high school in the United States, and in Canada at least it certainly does. And access to various things. And so this was to see, well, what happened? And we'll kind of walk through the team looked at various types of behaviors or components and challenges with autism. And they also broke it down into kids who had been identified with autism who had intellectual disability as well. And those in these graphs are going to be marked by the triangles, and the ones with ASD but did not have any ID. And those are marked by the squares. You can, for purposes right today, ignore the dotted versus the solid lines. Those are 2 subgroups, but they basically tell you the same thing. Now, we'll walk through each slide here a little bit here. What I want you to see here, again, pay attention to that 0 line there. That's when the kids are leaving high school. And this graph illustrates the success of interventions during the years of high school for behaviors, repetitive behaviors and maladaptive behaviors. And you see a distinct and clear reduction in symptom challenges over the 4 years before they graduate from high school. And if you look at these a little more carefully and compare the triangles to the squares, the kids with ID versus the kids who do not have ID, it appeared that prior to leaving high school is the ones that had no ID, the ones without ID actually responded most greatly or showed the greatest improvements over the course of the last 4 years of high school. Now, this is all good because this is all what we're supposed to be seeing. This is what we want to be seeing. We believe that interventions help and make a difference. And so this illustrates that these things are going on. What happens is that there's some marked changes that occur as soon as these individuals leave high school. And that's illustrated by the 4 years after. And so overall, if you look at the patterns, is that the rate of improvement reduces by about 50%. The slope shallows. So although there had been a significant trajectory pointing downwards, you can see how that trajectory alters right at the point of end of high school. And in this population is actually the kids, we were saying early, the ones with out ID are the ones who seem to respond the best early in high school. The ones who show the most slowing, not surprising, the ones that have the most gains are also the ones without intellectual disability. Now, all of that is to say that we have paid a great deal of attention to early intervention, very early intervention, brain plasticity, and focused on largely in our interventions the very early developmental period. But I think as neurologists, you all recognize that brain development continues well into the 20s, and I think reflects a lost opportunity for us, because we do a lot of investment of resources and time and money and interventions for kids, but if we are seeing them regress or fall back after we remove those resources when they age, is a real question about whether there's value that we're getting from it. So now I'm going to shift and try and see how these adults got to where they are. Why is it that at age 20, 18, we're seeing these deteriorations? And I'm going to talk now about my area of specialty, which is neuropsychiatry and developmental psychiatry and comorbidities. And my overall thinking is that I think at least a good portion of the regression or the challenges that happen have to do with unattended psychiatric issues in this population. Now, this is a set of illustrations just to point out how frequent mental illness and mental health disorders is across the population. On the right side, you have UK data. This could be from anywhere, basically, but it illustrates how common anxiety, depression, and so forth are across the population. I put this up here in part to highlight this other slide on the left side here, which is some data that we collected in some research we did a number of years ago on kids who had been referred for a question of autism. And we also looked at what comorbidities were present and found that if you have been referred for autism, there's a really, really high chance of having psychiatric comorbidity, though as you look at the types of psychiatric comorbidity, a bit different, not a bit, quite a bit different than the profile one would typically see with adults. So all those psychiatric issues do emerge very early with the kids in kids. What is important to note is that they're not the same psychiatric disorders that we call as we label in adult years. And this is more illustration of the same point. So in this study where we had a kid being referred for question of autism, and then we looked at outcome, what diagnoses they had. About 86% of kids over the age of 5, school-age kids, had a psychiatric diagnosis, whether they had autism or not. So in our population, we discovered this is a broad developmental mixed population, that if you're over the age of 5 and you're being referred, there is almost a certainty that you're going to have psychiatric disorder as well. Under the age of 5, not insignificant, but much less. And that certainly we'll see makes sense in terms of the natural history of a lot of the psychiatric disorders. That's on the right side of these two columns here. On the left side here are developmental comorbidities. So of the kids who have autism, they not only have psychiatric comorbidities, they also have other developmental comorbidities like learning disorders, language disorders, developmental coordination disorders, intellectual disability, and so forth. And that's fairly common. And the other final point I want to relate to this is that it's not just an increase in a diagnosis or comorbidity, but indeed many children have more than one comorbidity. And this illustrates that of that sample that we were looking at, say about 35–40% had one psychiatric comorbidity, but then almost the same amount of people had 2 psychiatric comorbidities, and somewhere around 10–15% of individuals had 3 psychiatric comorbidities. So multiple comorbidities, complexity, and this is where we get into areas of complexity, is not uncommon. 10–15% seems like a small number to some degree, but those are the 10–15% that get sent to people like me. And so they're more like 100% of the kids that I'm seeing are in that range. So, and now I want to kind of maybe just bring a couple concepts or label a couple concepts that are relevant here. One, I'm sure you're very familiar with this idea of diagnostic overshadowing. It's something we've talked about for several decades. The basis of it is that when someone has a quote unquote big label diagnosis, a major diagnosis, what ends up happening is it tends to preclude people from thinking about other things. Things get attributed to the big diagnosis without and preempting any further search to see whether there's other reasons for it. So, for example, if you have an intellectual disability, many challenges say, well, the person has an intellectual disability, that's why they're doing it. For example, you say Johnny has a mild ID and Johnny has trouble focusing on his schoolwork and class and is restless. And people might say, well, he's intellectually disabled. His focus is not going to be good, which is probably true. And so therefore, that's the reason we don't have to go any further. As opposed to saying, well, you know, he does have delays in intellectual disability, but this level of restlessness and inattention appear to be somewhat more or different than what would be ascribed solely to ID. And therefore we should look for something else like ADHD, and that might actually be something that is treatable. And so historically, and this still happens, is that one of the risks of having a diagnosis like autism is everything gets ascribed to autism. And it's a dangerous practice, because I think we end up missing the other sources of pathology, and then more complications will occur. Now, as opposed to diagnostic overshadowing, what I would propose is a process of diagnostic layering. And we're going to walk through kind of how my conceptual model of how I layer these things, because it is complex and it is hard to keep track of all these different things. But I think this is a more useful process. Now, I'm going to move into a set of illustrations that are conceptual, that give you a sense of how I think about things. So first of all, oh, this is going a little too fast for me. Well, so first of all, you can see this is the kind of green and red line there represents the average typical trajectory of any kid from 0 to 20. And we're going to, for the sake of argument today, assume that brain development stops at age 20, and then we're the same for the rest of our life. We know that's not true, but just for the sake of illustration, we're going to look at it that way. And so there's generally an upward trajectory in terms of skills and development. There are periods of expansion of skills and periods of consolidation of skills, so it's not even. And that's a normal trajectory. Now, on top of this, one can layer on things that happen, pathologies that emerged on typical development. And we'll do this in a chronological order now. And we'll look at, well, what comes on first, and then what comes on next, in the effort of both trying to understand what's relevant at what particular age when you're looking at diagnoses, but also what other things you should be looking at that period of time. So the first, and I think I would say core difficulty that one would identify in kids is IDD, intellectual disability. Now, it doesn't mean that we identify intellectual disability very early. Clearly, mild IDs get picked up often quite a bit later, if at all. However, certainly the potential of picking up an intellectual disability is there in the first few months of life. There are kids with severe to profound ID. We may not call them ID at that point. We might use this vague term called GDD, but certainly they're likely to grow up to be individuals with intellectual disability. So that's the first thing. So if a kid's coming in at age 1 or 2 and there are some significant challenges with their adaptation, probably one of the first things one is going to look at or be wondering about is, do they have a delay and do they have an intellectual disability? Now, this is how psychologists and our testing describe IQ. It's certainly accurate, but even for me, horribly confusing and hard to apply to individual patients. It's hard for me when I see an individual say, what do I take from this that's going to help me understand this individual? So a number of years ago, I developed another way of kind of illustrating IQ and development trajectory. I did this because initially for parents, because parents were receiving that other graph when they got their kids diagnosed and being explained that they had an intellectual disability and left with that, but really didn't have an understanding of what that meant in the future. And they would come in to me, when the kid was 15 and say, doctor, that, Johnny, they said he was delayed, but he's getting worse. And so I needed to explain that to them. And this is kind of what I did. So what I've done on this graph is conceptual again. I've placed two data points here, the chronological age, which is along the axis, 0 to 20. Again, we're going to use that as the baseline for development, and then mental age or age equivalent, 0 to 20 on the vertical. And so in a kid with an average IQ, meaning 100, there is a one-to-one correspondence by definition between mental age and chronological age. And so at each data point, there is a straight line, and you see this very nice upward trajectory for typical kids. Now, if you now plot what it would look like for someone who had a mild intellectual disability, say an IQ of 65. Over a course of 20 years, this individual will also learn and gain and make gains, and will, if things go reasonably well, be on a relatively smooth trajectory. But when they finish their development, a kid with a mild ID, we're expecting and hoping that they will get to about a 13, 14-year-old age equivalent. That's kind of the ceiling that we assume. If you look at someone with a moderate ID, then say with IQ of 40, similarly, they are on an upward trajectory overall. However, they're not on the same slope. And so their endpoint at moderate ID, when they finish the development, if all goes well, we're hoping to get them to a 7, 8-year-old age equivalent. And you can do the same with someone with a severe ID, where they're ending up hopefully at about a 5-year-old age equivalent by the time they finish development. Now, many things you can look at this tells you about. One is this concept of the gap widening. And many times I hear parents or others say that we think that there's regression here. This person's regressing. He's falling further and further behind his peers. And that leads to all sorts of aggressive investigations, which more often than not produce nothing, largely because there isn't a regression. Largely because the gap is supposed to widen. That is predictable, but we just don't tell people this, and we don't explain it properly. But we are expected kids to actually further and further fall behind. That's just the kind of the core aspect there. Now, so going back to this other conceptual model, we've started with intellectual disability and kind of illustrated how those various arms and slopes will work over a course of a lifetime. We can now move forward in this child's life and see, well, what else is coming on? So now they're out of the neonatal period, out of the infant period, and they're entering into kind of toddler years and preschool years. What are the next things that start to show up that we start to pay attention to? Well, that's when the other developmental disabilities, other developmental disorders other than IDD start to emerge. That's kind of the first other problem area that typically emerges. And the two prototypes for that are obviously autism and language disorder. And I put them separately than intellectual disability to some degree because we conceive of autism and language disorder as modifiable. We, as a general rule, do not see intellectual disability as modifiable. We cannot improve your IQ. We can try and prevent it from regressing, and we can try and maintain your skill development to your maximum, but we can't change it. The theory, this is a theory, and it's arguable, is that autism and language disorder and things like that are different. And they're different because if you do something specific with them, whether it's pharmacologic or non-pharmacologic or whatever, that the trajectory will change, the outcome will change. So they're actually modifiable. And this is kind of the basis of why, at least in North America, there has been such a effort to proactively identify kids with autism and provide them early intervention, because the theory is that if we can identify this early and this is modifiable, then God damn it, we should get in there and do it really, really quickly. Now, again, I keep saying this, but this is still a bit of a hypothesis, and I'm not sure how well the theory is panned out. One of the things that I just want to illustrate here just about autism, because it does operate somewhat differently or just manifest somewhat differently than a lot of the other developmental disabilities, in the sense that most of the other disabilities are all focused on deficits, things that kids don't do that they should do. They don't walk, they don't talk, they don't socialize, things like that. Autism has a lot of those things that they don't do, shouldn't, and should do. However, autism is unique in also having things that they do that they ought not to do. These are the positive features. And so as a clinical syndrome and just how we kind of think about it, I actually see autism in a lot of ways more like the way I conceive of schizophrenia than I do ID, in the sense that there really are two arms to it. There's the negative symptoms and the positive symptoms, the not talking, the not socializing, the not making eye contact. And then there's these positive symptoms, the repetitious speech, the peculiar interest, the motor stereotypies, and so forth. And both of them are relevant. Both of them have different degrees of relevance. And in some respects, the positive symptoms are often less clinically relevant in terms of functioning than the negative symptoms. And this is true in schizophrenia. It's the amotivational syndrome, perhaps, that has the greatest long-term impact on outcome than the hallucinations. And I think in similar ways, autism can be seen in that way. Now, so we've got the core layer, we've got the modifiable layer of other developmental disabilities. Now we're going to go to the third layer up. And the third layer is what I'm going to call treatable. Now, this is just I'm developing kind of suggesting kind of a term to classify this. It's not hard and fast, but I say treatable and I say psychiatric because these are a set of disorders that have been studied independently for a number of years, particularly with a focus on neurochemistry and neurobiology, and in association with pharmacologic research, and much more so than developmental disabilities ever have. And as a result, for better or for worse, we actually have some really effective pharmacologic and non-pharmacologic treatment for these conditions, and we can treat them. Not only can we modify them, we can treat them. We can at least reduce severity, and sometimes we can actually even eliminate the disorder. Now, that's not true for these other things. And that brings increasing relevance to this in a kid who also has intellectual disability or other developmental problems, because as I showed you those graphs there of developmental trajectories, one of the things that we do in our business is try to keep kids on their slope. And the biggest risk a kid with autism has is falling off their predicted slope. And that happens not infrequently later in later years, in high school and adult years, I suspect in large part because of unattended third layer. And that's where a lot of the activity that I have clinically is identifying this third layer. And so now we're going to step into, well, how does one look at this third layer? And again, I'm going to try and propose that there is a organic, natural history here. And the more cases I see, the more I'm convinced of this pattern. And it stands somewhat distinct from models that are proposed by ICD and DSM, in part because, well, many reasons, but one main reason is because those models are based on what adult mental health and psychiatry has formulated as a classification system for adult disorders, and then by extension presented to children, which doesn't often work. And we'll kind of see a little bit of why. So we've got your base developmental conditions, and now you've got a kid at 3 years of age. What are the next things that you're likely to see showing up? Well, the next things they're likely to see showing up are the set of anxiety disorders, the early onset anxiety disorders. And they're all really the same. They have different names in DSM, different labels, but in my experience, it's almost impossible to identify only one. Usually there's a mishmash of several different types of anxiety. And this cluster particularly is a common one. It starts with separation anxiety, it moves to selective mutism, and then it moves to social anxiety. The separation anxiety may diminish as kids get a bit older. The selective mutism may also diminish as kids get a bit older, but the social anxiety kind of carries it forward. You generally see this sort of trend. Now, you may pick up a kid at various times, so they may come into the office at age of 10, which sounds like clear social anxiety. But if you dig and you take the history, more often than not, you're going to find that, yeah, this didn't happen just at age 10. This was an anxious kid at age 3. There was a lot of stranger anxiety, a lot of separation anxiety, and a lot of social anxiety. Now, this is relevant, particularly in early school age, because one of the things with kids with autism is that they don't talk, or they don't want to talk, even if they have language. That's the same thing that happens with kids with selective mutism. The other thing that happens with kids with autism, they don't like to socialize, or they have trouble socializing. Same thing happens with social anxiety. They have trouble socializing. Now, if you have entered the system with a diagnosis of autism and you're now 5 and you're going into school and you're having real difficulties with social engagement or speaking in public, and you assume that everything is related to autism and use autism interventions, you're going to miss this. And if you miss this, that anxiety ain't going to go away. And we'll see how it ain't going to go away. And more importantly, your interventions are going to get very complicated to administer unless you address the anxiety. Shortly or concurrently around the same time, the other family or other set of early onset issues emerges ADHD. Now, ADHD, probably, if you dig back, probably every kid who ultimately has ADHD, you can tell by the time they're very, very young. However, it's not a very specific at an early age. A lot of kids look like they have ADHD younger on, and then they outgrow it. So reliably, we don't like to make diagnoses and confirm diagnoses until kids are 4 or 5 years of age, typically. And so the typical age that we would see kids identified for or referred for this question is going to be in early school years as a general rule. And tic disorders, which represent repetitiveness and interrupting behaviors, which is another set of issues that many of our developmental kids have, come on a little bit later. Typically, we're seeing these things emerge around age 5, 6, 7 years of age. Now, this is an important thing to keep in mind for a variety of reasons. One is differential diagnosis. We are always trying to identify for various behaviors what are the potential etiologies for this. Repetitive behaviors in particular are something that we see and we pay attention to in autism and are part of our diagnostic criteria. One of the things that I see happen not infrequently for older kids being referred and assessed for autism is that repetitive behaviors that are not autistic start to be included. And if you don't pay attention to the fact that kids with autism very frequently also have tics, you cannot, it's possible that you're going to mislabel some repetitive behaviors and see them as part of autism as opposed to as part of tics. Two implications of that is if you see them as part of autism, stereotypies, we don't actually do very much about stereotypies in terms of treatment, and we don't provide any, we just kind of leave it, as opposed to tics where we actually do have some treatments available if they are particularly problematic. So if you're seeing a kid by the time, when they're 2 or 3 years of age, at the very front end here, there isn't a wide differential. I mean, there's only 1 or 2 things that could be happening. As you can see, as these kids get older, there are multiple things that could be happening. And it could be any one of these things, or it could be more than one of these things. Right. Functional challenges in terms of development start to become more evident, or we start to pick them up. We don't certainly identify learning disabilities, developmental coordination early on. So in early kind of middle school years, these are some of the concerns that we start to pick up. Why is this happening here? And then in later adolescent years, more anxiety. So the anxiety disorders, I tend to see them as a continuous evolution. And so separation, selective mutism, social anxiety morph into generalized anxiety frequently. Sometimes they go into OCD, but they're generally part of the same pattern. Rarely do I see one of these things in isolation. And catatonia, which is another interesting condition we won't spend a lot of time talking about today, is another thing that we see emerge sometimes in late school years. And what you see here is that the headline diagnoses for adult psychiatry, for adult mental health, schizophrenia, depression, bipolar disorder, really are not disorders of youth. Some of them emerge, bipolar disorder, depressive disorders. Really, the onset of these disorders is post-pubertal. They do occur sometimes pre-pubertal, but as a general rule, depression and bipolar disorder are not disorders of early childhood, which is, I think, another mistake people often make. And seeing younger kids is diagnosing depressions, which really don't exist. And then schizophrenia, which is, again, a late onset. Now, schizophrenia is different than autism, and for a time, people would die, and even here, people diagnosed would change the diagnosis from autism to schizophrenia for individuals when they hit adult years, but clearly it's a very, very different disorder. And I put this slide up just to remind everybody that not only are we dealing with multiple possible comorbidities, but there are multiple things that could happen concurrently. So here you see that the number in the study of individuals with autism, with developmental disabilities, the number of comorbid psychiatric diagnoses is not insignificant. 25% had 1, another 30% had 2, 10% had 3, 4, and 5 go on. And so it's quite likely that when you're seeing a complex individual, what you're seeing is 2, 3, or 4 of these colored bars here operating concurrently. And it's our job clinically then to try and sort out what is the source of the particular challenge, and then direct treatment that is evidence-based for that, rather than more generic, kid has behavior problems, let's just do behavioral intervention. Is what is the source of the behavior problems? Is it one of these things that is treatable, that we should be focusing on? Okay. Now, this is another conceptual slide, and it's very colorful and a little confusing. We're going to unpack it a little bit. Let's pause for a moment and just give you a sense of what this is about. This is a table that I developed a number of years ago because when I was doing autism training, autism assessment training, and with the ADI and the ADOS, and one of the things that came up very early on was that there are a number of behaviors or features that we were taught or we were teaching to look for in autism and making a diagnosis, things that are on the ADI or the ADOS that were presented initially as being kind of unique and distinctive for autism, but in fact, they're not, that there are a number of behaviors that we look for, or that you see in autism, that are also shared with other disorders. And that's where some of the differential diagnosis confusion can arise about them. So what I've done here is on the left, on the vertical list here, I've put down a number of behaviors that we associate with autism. These are all derived from things we either ask about in the ADI or we observe in the ADOS. So these are distinctly autistic type of behaviors. And I've marked the first column all green, autism spectrum disorder, because by definition, these are our symptoms we're looking for. Any of these could occur in autism. They don't always all occur, clearly, in every kid, but any of them could occur in autism, and that was marked by green. Now, as you move to the right, I've placed a variety of other childhood onset conditions, developmental and psychiatric. And then I've done a mind experiment with each of them. And you can do your own mind experiments with them, but with mind experiments, what I did was I looked at the syndrome and I looked at the behavior. I said, well, which of these behaviors could I also see occur in the syndrome? And which of these really I wouldn't see as part of this other syndrome? So, for example, with ADHD, do kids with ADHD typically have problems with eye contact and gaze? Yeah, very commonly do. Different than autism, but commonly they do. Do they have lack of interest in peers? No, not generally. It's not something that I would typically see with a kid with ADHD. They may be unsuccessful, but I wouldn't see a lack of peer interest. And so you can kind of go down each of these various disorders, ADHD, social anxiety, selective mutism, GAD, OCD, and then you move toward the right. We also have developmental disorders, ID, language disorder, FASD, and I've populated it with these reds and greens. And one thing you can take away from this is that if you're looking for autism as opposed to any one of these other disorders, there's a lot of distinguishing points. There's a lot of areas of red that really do help you kind of separate them out. The challenge is, as I was saying, these things don't travel in isolation, and more often than not, you're dealing with more than one in combination, which gets very hard in the math and the color scheme. So if we kind of split this up a little bit, just to illustrate my point here, I've diced up this graph, and here we're looking at just the autism. And again, all of these things are green because all these features can be present in autism. And now we're going to move forward and compare it to kids with a variety of other childhood onset conditions. So here I put together all anxiety disorders. And I say all anxiety disorders because I've lumped together separation anxiety, selective mutism, social anxiety, generalized anxiety, OCD into one. And if you met any of those, they're kind of added together. Why did I do that? Because as I said, in kids, rarely are you seeing these things present as separate disorders. More often than not, there are continuous between them. And as you see, if you're comparing a kid with just autism, you're trying to figure out what's responsible for various behaviors. The areas of red, areas of discrimination start to diminish, but there's still some very distinct areas that would rule out a kid with a lot of anxiety having autism, would be things like early pointing, prodecorative pointing, odd communication patterns, neologistic speech, imitation play, and so forth. Those are things you don't expect to see happen, and they allow you to discriminate between autism and anxiety. Then you've got, I put here is that the what we call the neuropsychiatric triad, ADHD, tic disorders, and OCD, that common thing that travel together. And if you put all those three together, and that is a common sort of thing, what do these kids look like? And again, you see that there's areas of commonality, but a lot of areas of distinction between kids with just autism and that, and it shouldn't be too hard to separate them. My clinical experience is that the OCD triad generally doesn't travel just with OCD, neuropsychiatric with OCD, but generally merges a whole bunch of other stuff too. And so these are kids with all sorts of psychiatric issues. They have selective mutism. Often they have 4 or 5 concurrent psychiatric diagnoses. So in this theoretical mind experiment, if I put together all psychiatric diagnoses, they had ADHD, a tic disorder, and an anxiety disorder, how much could I say, well, of their various, what were looked at as autistic features be explained by autism alone? Well, a lot. It starts to get very, very difficult to separate out these complex kids, well, what's autism and what is not. But there's still some kind of core things. And this is where we start to get, pay attention to the more specific symptoms of autism, the prototypical symptoms of autism. And when you're getting into these complex kids, that helps you just determine. For illustration, we can also compare it to kids who have just developmental disabilities. So here I've kind of put together kids who have ID, language disorder, DCD, learning disorder, and just DD, looking at that compared to autism. Again, there's areas of commonality, but a lot of areas of distinction. This is really useful because this is really the basis of the strength of autism ADI, is that its initial norming was against other developmental disabilities. And it's very reliable in being able to distinguish from other developmental disabilities if you don't have these other three things going on. However, when you put this all together, and you say you have a kid who has ADHD, anxiety, autism, ID, DCD, and a language disorder, what you end up seeing is the complexity gets so great that it gets almost impossible to separate out what is autism from what, I should say almost possible. It gets very complicated to separate out what is autism from what is not, because almost everything that you're now seeing is potentially related to multiple etiologies. So this is relevant in several ways for us. One is clearly at the front end in terms of diagnosis, and we're seeing kids and we're trying to sort out what is the source of the problem. This is, I think, even more relevant to the point that I'm making in terms of adults and kids growing up, is that it's hard if you have a kid with autism and all these green spots to know when they develop some new behavior, whether we can now ascribe it to something emergent or new, or whether it just goes along with the previous. But my point and my thrust of my argument here is that if you are anticipating these things happening, if you assume these things will happen, or at high risk are going to happen, that if you know that 40 to 50% of kids with autism will develop anxiety, you know to look for it. And you know when it likely will show up. You know that at 3, you're probably not going to be paying attention to it. But when this kid shows up back in your office when they're 8 or 9 years of age, you need to be paying more attention to it at that age. So it should guide your intervention and your understanding of what you're looking for as well. All right, so to summarize, individuals with any developmental disability have challenges in lots of domains. If it's not clear already, interdisciplinary lenses for everything are critical in order for us to best manage and support these individuals. They often have multiple and complex psychiatric comorbidities that have direct impact on functioning and outcome. And they are well into evolution. We need to move away from this idea of early intervention being the gold and really think about intervention as being a lifelong process. And for quality of life, we are as interested in maintaining quality of life in adults as we are for their child predecessors. And I believe that is my last slide. Yes, it is. So I will stop there and turn it over to my moderator.
Thank you, Dr. Vikram. Can you answer a few questions?
Absolutely.
One of the questions is, does treatment of multiple psychiatric conditions, that's comorbidities in adolescents, improve the outcome in terms of function?
Yes.
Possibly the main children days.
The question, I think, is, does treatment of these multiple comorbidities result in improved function? Is that the question?
So there's another question. What ability of this cancer in the bodies? What's the best way to exert IDHD? What's that tools or method worldwide? Do we look at adaptive skills and make a judgment of their
I'm sorry, I can't, I didn't understand what you said.
with
Your line's a little choppy.
with abilities often scattered in an individual with autism? What is the best way to assert an IQ in children with autism? What's the accepted tool or method? Do we look at the adaptive skills and make a judgment of their cognition?
Okay,
It's in the
so
Q&A. It's in the Q&A actually, if you want to. It's
in the
Q&A.
webinar chat or in the Q&A?
Q&A.
Q&A.
It's in the
Oh,
Q&A.
the Q&A is in there. Okay. All right. So, okay. So questions with the ability scattered individual with autism, what's the best way to ask IQ? Okay. So I'm not a psychologist. And I can't speak to, the technical aspects. I work with a lot of psychologists, and different diagnostic tools are used. I think what I would say is that I hear this a lot, is that this kid is not testable. And I think that's garbage. Every kid is testable. I think we can get a good psychologist or developmentalist can get a reasonable developmental estimate of a kid from a variety of ways. The tools, it depends on how, what age the kid is and what level of development they're at, but anything from the WISC or the WACE or the Stanford Binet or the Merrill Palmer or the as you go down further, the Bailey are possible. I think adaptive measures are critical, but they're not going. I think it is really important that you do establish whether this individual has an ID or not at some point. It's sometimes very challenging to do so when they're 3 or 4. You have a sense that they're probably delayed, but you don't know whether the delay is secondary to autism and with the intervention that they'll catch up or not. But by the time they're 6 or 7, it's pretty clear. Rarely are you seeing kids who look ID at 6 or 7 who outgrow it at that point. I don't know if that answers the question. Did that answer the question,
Shall we
Maya?
go to the next question?
One second,
What would
Mary, before that, we'll just have the experts speak 1 second and the opinion before. You can ask one by one.
Yeah.
Dr.
Dr.
Tuba can give the
Tuba.
opinion. Yeah.
Well, that was a great presentation. Thank you, Dr. Vikram. At the end of the day, the parents and the schools, what they really want is how can we provide services, and is this service at the level that this patient can thrive with, right? And so if we are providing services that are towards a child with autism and mild to moderate IQ deficits, and they thrive with that, that's great. But if this child has autism and severe intellectual disability and is getting services that are geared to mild to moderate IQ deficits, that child's not going to thrive. So we really need a really nice platform to relate and explain to this parent and really relate to the school that this is what this child is capable of. This is where we see their potential in a few years, and this is what we think they'll really thrive with this specific sort of therapy. And that's why at the end of the day, we can call it IQ, we can call it, an IQ level of below 70, but we can have kids that have IQ levels of 60s and still may not understand and have deficits in severe adaptive functioning, such as not being able to be toilet trained. And then they don't thrive in school or in therapies as much as someone with more IQ deficits, but that is toilet trained. And so that's the beautiful thing about seeing a child with autism, is you're not just seeing their social deficits, you're seeing their whole adaptive functioning, and you're providing that information. And so where are the strengths of this child that we can hone in during therapy and behavioral increasing what they can do in their future? So along with IQ, we also need to see how well they do with other things like occupational skills and adaptive skills. So I'm not a fan of just IQ testing. I believe in IQ testing and in adaptive function assessments.
Absolutely,
Dr.
everything has to be taken into. Yeah. Dr. Mary, please.
Maybe I could speak to some of the other questions here. There's a kind of theme here, two questions. One is, what's the ideal approach to overcome separation anxiety and selective mutism? What are the main reasons behind mutism? And then another question is treatment of multiple psychiatric conditions and adolescent improved functioning? So I'll answer the last question first. I'm a strong believer in treatment and pharmacology. Strong believer. So what can we do, Maya? I mean, I'm looking at this not only, I'm primarily looking today at this as a physician, as a psychiatrist. What can I do? What's in my tool bag? And so what I know is I have some very effective tools in terms of pharmacology, and I know that they can work. So I think it's part of the reason we're looking to identify what I'm suggesting that we pay attention and we're proactive in looking for these things is because they are treatable. And I do believe that you will see substantial functional changes if you treat them, independent of any other resource implications. Now, the question about in a 3 to 4 year old group and they have separation anxiety and selective mutism, what do you do? Now, that's a really, really good question. And I think that really there's a divergence in thought on that. I would say that the traditional school of thought is this: is that if you know the kid has selective mutism, separation anxiety, I don't think there's any treatments for it. I don't think anybody really does anything for it. It phases out by itself generally, or morphs into something else. But selective mutism, sometimes it does show up, and people do try to treat it. And I'll see these kids occasionally when they're very young. And I think most people at age 3 or 4 would say use behavioral approaches. You see it as a phobic anxiety disorder. What do you do with phobic anxiety disorders? You use exposure and response prevention modalities, and hopefully that diminishes over time. The downside of that is that when I first started doing this work 20 years ago, 30 years ago, and I would follow that and I would say, I see a 4 or 5 year old, I'd say, yep, go and do behavioral stuff for 6 months or 8 months. It doesn't work, come back. Then the kid would disappear and I would see them 3 years later, still not talking. Nothing had happened. And it started to worry me, this pattern. And so I, as a result, have gotten more aggressive. And I will lay out for parents of even very young children, not that often that I see it, but 5 and 6 year olds say, listen, this is what I think. I think she has an anxiety disorder. I don't think it's ever going to go away. I think this is part of her makeup biologically, and it's going to get complicated and it's going to cause more problems. I think that if you don't treat it right now, it's not going to get better, and it's going to get worse. We can wait, but the only thing you can do by waiting is creating more difficulty later on. So it's up to you. I understand there's all these risks, and we don't know about treatment absolutely in 5 and 6 year olds, but you have to kind of risk-benefit analysis here. So I tend to be more assertive in that. And that goes to the last one. What are the main reasons behind mutism? It's biological. What are the main reasons behind autism? It's the same thing. It's the same brain wiring stuff that's happening that's abnormal. I don't know the specifics here. It's all connected. It's all connected. I mean, the reason why we see social anxiety at 40% or anxiety disorder is 40% of autism is not because being autistic makes them anxious. It's because anxiety travels with autism. So I think one of the things we do with mental health conditions frequently, and we have to stop doing this as a profession, is we say, if they have a mental health experience, a depression or something, well, why? There's no good reason for that. We want some social reason for it. Some moral judgment, again. This goes back to moral judgment around things. We don't do that, like, well, why do you have autism? What did we do to create? I mean, some people do, but I think we need to be thinking about these things as being distinctive.
One more question, Vikram, in the chat.
Treatment of multiple psychiatric moment, but I think I did address that.
He did.
Yes.
Then
we can
thank you,
have
Dr.
from the
Vikram.
expert.
Thank you, Dr. Vikram. Dr. Session, please give your comments on the topic.
At first, thank you very much for your excellent presentation. I agree with your comments. Maybe I can add what should we say to parents about separation anxiety and mutism. I think parents also deal with their anxiety problems. Maybe they have anxiety disorders. I can this and I prefer them to avoid overprotection of their child, over criticism of their child. Maybe they can do this, and they should give opportunities to their children. I think these suggestions can give to parents besides your suggestions.
I think your points are. I agree with you. Let's spend a moment talking about that. You're absolutely right. Anxious kids almost always have one or two anxious parents, invariably. And I think you're right that leads some parents to overprotection and lack of opportunities, and that actually compounds the problem. I agree with you there too. But the other thing, this is, I think, a really important concept that I believe in, is that anxiety is like pain. I think about anxiety like pain. No normal parent wants their child in pain, right? It's just, you see a child in pain, you're going to do anything you can do to prevent that pain. The same happens with anxiety. It's a normative response. If a kid's anxious, swoop them up, take them out of the things that make him anxious, save them. It's just a normal response. That's accommodation. But then it becomes so accommodated and so habitual that the child starts to rely on this level of scaffolding, and then you're stuck there. And so you're right, I think, in the sense that there's overprotection. But the overprotection doesn't come only from the parent's anxiety. It does. But it also comes from, when I see it, and I'm not the parent and I'm not protected, it's like, oh, please stop. Don't, like, there are times where I'll be doing interviews with socially anxious kids, and it's clear that they're just about to burst in anxiety. And I was, okay, let's stop. This is too much, right? It's too painful talking about it. So I think that's the other part, is that, and I think acknowledging that with parents, because parents feel guilty. They often know that they're being overprotective, but they don't, like, oh, I know I shouldn't be. I know I shouldn't be. I know I should. And then if you have a child who's thought to be vulnerable, they have autism already, right? Then it's like, oh no, we got to protect them. We got to do this. We got to do this. And so then those opportunities get even compounded even further. But I think you're absolutely right. Those are things that are important to do, and I think are part of all this. But again, it goes back to, now you've got two people with anxiety, and maybe you got to get both of them treated.
Thank you for this topic. Dr. Ibrahim, expert on topic. Dr. Ibrahim,
Javed, Dr. Iram Javed. Yeah, we can't hear you.
Yes, am I audible? Hello,
Yes,
good evening.
yes.
Hello, am I audible?
Yes, you are.
Good evening, everyone. Okay, fine. So, what I'm supposed to talk about, the question?
No, you are supposed to tell about, with reference to the exceptional talk Dr. Vikram has given, your experience with such children in Pakistan. And are you agreeing with it, or there are certain
Yeah.
other issues you would like to add on, which may not have been discussed, is the idea? I mean, yeah.
First of all, I would like to congratulate Dr. Vikram for such an elaborative talk, and he has covered all the aspects so nicely that I have learned a lot, especially the table that he made, where he explained the overlap phenomena in all these disorders. So, being in Pakistan, that is a resource limited country, we are still striving for one window model these disorders. We do not have one window model like where all the diagnostic facilities, with the neurologists, the developmental pediatricians, with the therapists, all are available under one roof. And that is big challenge in managing such children. As we know, because only one neurologist or one developmental pediatrician cannot do much for these children. And as far as the therapists are concerned, their training is also very important. At which center they are trained, and what is the level of their training, and how to deal with these children with these comorbid conditions. They are not a simple autism. They are complex with many comorbidities, and how to deal with them, especially the medical conditions. So we are still striving to deal with these children. The main role is of a clinical psychologist when it comes to the anxiety of the parents dealing with these children. So the parents also need psychological support to deal with these children. They need to be constantly motivated, because when we disclose to them that their children are suffering from autism spectrum disorder, they are in denial phase. They stop visiting one neurologist who gave them diagnosis, and they move to another neurologist to seek second opinion, then another third neurologist to seek third opinion, and they waste that window period or the critical phase period during which the intervention was most important. So we are facing these challenges in our country. Still, we are facing these challenges in our country.
I understand these are a big challenge.
So, we need an international collaboration, free online courses for these therapists so they can update their knowledge and training skills, so they can provide their services free of cost to the resource limited countries. So at this forum, I would like to take this opportunity to extend my this heartfelt need for these kids.
Certainly, we'll develop collaborative thing. Vikram has been hand-holding for us in India. I think now this time has come to expand to other SAARC countries. I think, Vikram, we can, I think you'll be happy to train, right?
I'm not making a commitment right now.
Yeah, I'm just saying. Anyway, we'll be bringing out some packages from the AOC in India. That's so that will be fine. And John, Dr. John, from Indian side, would you like to add on after the wonderful, amazing talk by Vikram? And I also am a fan of your table, and I think that was hard work and experience for over years that you made that. That is a very nice one. John.
Yeah. Good evening, all, and thank you, madam, for inviting me as a panelist. And it was a very comprehensive, as always, the session by Dr. Vikram. And I'm also part of the Indo-Canada Autism Network with Professor Shefali and Dr. Vikram and several other clinician researchers from Indian context. So what I could from my experience, what I would like to say is that both the neurodevelopmental as well as the psychiatric comorbidities, they are quite common in children with autism spectrum disorder. And as very beautifully elucidated by Dr. Vikram, that the lifespan and the trajectory approach, wherein right from 3-4 years of age, I think we need to be aware, he had listed multiple conditions like intellectual disability, selective mutism, anxiety disorders, ADHD, tic disorders, etc. And later, during the adolescence, anxiety and conditions like generalized anxiety disorder, mood disorders, etc. We need to understand about these disorders, the criteria of these disorders, and we need to ask for symptoms of these conditions. And the challenge in children with autism, especially those with severe intellectual disability as well as severe autistic features, is that oftentimes the comorbid issues may present with more of behavioral symptoms like aggression and increased repetitive behaviors or self-injurious behavior, etc. So the child, due to the very limited expressive language skills, may not verbalize and talk about anxiety. So there may be a group of children whom we commonly refer to them as children on the high functioning side of the spectrum. Especially when they reach the adolescence age, they may express anxiety, they may talk about situations that cause anxiety. And also one important point which Dr. Vikram mentioned is the family accommodation that takes place for anxiety. And oftentimes what happens is in milder cases, the comorbidities are missed in the earlier stages because help seeking doesn't happen in time. That is an experience we have seen in our context. Only in those moderate to severe cases where the behavioral problems become very intense, and even in the home settings as well as school settings, it becomes unmanageable. That's when the parents come for additional help seeking, especially for the treatment of the psychiatric comorbidities. Otherwise, it is like usually the parents with the primary diagnosis of autism spectrum disorder, they will be thinking that with the core deficits of autism spectrum disorder being handled by speech therapy and other behavior therapy and other forms of non-pharmacological management, they think that that will suffice and that will be able to handle the whole gamut of psychiatric comorbidities, which is not true. And in fact, Dr. Vikram had highlighted that the role of medications, especially the use of low-dose atypical antipsychotic medications for aggression, and even for mood disorders. Sometimes, especially in the adolescents, we have seen some of them require not just antipsychotics but also the addition of mood stabilizers like either lithium or valproate. And for anxiety disorders and some of the repetitive behaviors, we use the selective serotonin reuptake inhibitors. So the role of pharmacotherapy is also very important. And the last point I would like to add is that though we have not published the data yet, but recently we have had some experience looking at the outcome of these kind of conditions, not the long-term outcome, at least for a period of 6 to 7 months. What we see is these psychiatric comorbidities seem to be stable diagnosis. So that's where once they reach the diagnostic threshold of a disorder, they seem to be relatively stable and they seem to continue. This results in significant impairment in functioning, and it adds on to the caregiver burden of the families. And that's why I think it's very important as a kind of in the psychoeducation part also, right from the 3 to 4 years of age, we should utilize the opportunity. Of course, I would say that not in a very scaring way with the parents, but at least we should give the information saying that it's likely, because close to almost 70 to 80% of children have one or the other comorbid condition. Sometimes we see multiple comorbidities. So to educate them about comorbidities, that is the opportunity we have to use whenever they seek help. These are my experiences. Thank you.
Great comment.
Add on to what. Please continue, Vikram.
No, is it?
Yeah. I was wanting to add, what he is saying. I'm just adding the figures to the similar figures, like we just analyzed 1,874 children and 80% had comorbidities. The commonest was around 57% having ADHD and 1/4 had multiple comorbidities, as very rightly John has just mentioned. The similar thing we are having. And when we saw 130 mothers and 76.8% had depression. based on the DSM-5, and so I mean basically it was not so we have to see from both the child's perspective and the mothers and coping strategies and all to be put in place. I think a holistic evaluation is very important. B is a full family counseling and telling them, as John said, they have to be aware of how the trajectory goes, so they have to be preempted about it, and that is very, very important to understand. And one problem I have with sometimes, I will be apologizing to the therapist, but many times when we prescribe, the therapist will say, please don't give the medication, but we will, the child will become better once without the medication. So I think, and the parents have a taboo that they feel it will be addictive. So they have to be proactively told that they're not going to be addictive. I mean, that is something very important. And before I hand over to Mary, to you, and Dr. Kalra would like to add something here, and then Mary's comments, and then we can have one case. We have only one case too. Dr. Kalra? Dr. Veena Kalra? Mary, you can take up. Whenever she's there, you can allow me. Your comments, Mary. Then you can have the case.
The exposition was excellent, and it has brought to light how you can see an ordinary case in an investigative modality. What normally we do as clinicians is you try to find out the root cause and try to treat that root cause so that single child becomes normal. But it is also important, as was stated in this forum today, that we look in an investigative manner to look for what are the problems about with psychiatric problems. It's another way of getting it. So remember the really fun every time. Like we have the important or a bonding problems and go on to the next phase by Dr. Davis. Researcher. Dr. Rengi Kumar Manohar, the moderator. Over to you, Dr. Rengi. Dr. Priyadarshini, please share your screen.
I'm sharing the screen.
Good evening, everyone. It's a good opportunity for us at Ramchandra Medical College to have this presentation in front of August audience, including Dr. Veena Kalra Madam and Dr. Shifali Gulati and Dr. Vikram Dua. And I think the case actually goes based on two trends. One is the increasing number of dysmorphic features which we are seeing in children who are diagnosed with autism spectrum disorder. And the other thing is, we had a meeting with Fragile X Society India and Dr. Randy Agerman, over which we discussed. She was talking about how Fragile X was underdiagnosed and treatment options that are available and the various dosings that are available. Based on that, I think we did a small study of children who fit into the features of Fragile X syndrome with the phenotype of either autism spectrum disorder, ID or ADHD. We did around 50 samples and 3 of them turned out to be methylation positive for Fragile X. And one of them refused treatment and 2 of them, I think this is the first child who has continued treatment for about 2 months or so. I think at the end, I would like to have the opinion of people on the usage of this drug in Fragile X condition. And I also want to thank my co-moderator, Dr. Anjit, because of whom I think I'm able to make this presentation in this podium. Thank you all. Over to you, Priya.
Thank you, sir. Good evening, everyone. I'm Dr. Priyadarshini. I'm from Karthikeyan Child Development Unit, SRMC Chennai. I'll start my case presentation. Can you all hear me?
Yes, please start.
Yes, ma'am. Thank you. Starting the case, ma'am. Master J, a 4-year, 7-month-old male child who's a second born of non-consanguineous marriage, was bought by parents whose reliability is good. He has been diagnosed with autism spectrum disorder at 2 year 10 month and have been advised appropriate therapy. Parents has not initiated therapy and he is currently attending play school and daycare. Parents brought him with concerns regarding speech delay and behavioral issues to our unit. He has marginal gains in eye contact, imitation, and motor skills. His vocabulary remains limited to approximately 15 words, but not making 2-word sentences. He demonstrates proto-imperative and proto-declarative pointing. He can obey 2-step verbal commands, sometimes with prompts. He responds well to name call now, but not telling his name when asked. He imitates actions and activities. He engages in some play activities, but lacks written play and sharing of interests. He likes to be hugged. He understands emotions and reacts to some extent. When angry, he displays self-injurious behavior. He hits on his head, on people and things. He shows when he gets hurt. He enjoys throwing a ball and stacking rings. He hums and does action of few rhymes. He scribbles, can put horizontal line but not copy a circle. He has fascination for wheels. He mingles with other children now, engages in associate play, but not engaging in cooperative play. He greets spontaneously only when going out. He points to few colors and shades. He recognizes few pictures. He likes to flap books or papers. He's hypersensitive to sounds, hand regard, unusual touch was present, but now these things are decreasing. He started walking at 1 year, 3 months. Now he can climb upstairs and downstairs. He tries pedaling cycle. He's not hopping. He has fixed routine for mealtime, gets agitated when his meal timings are changed. He doesn't have echolalia, no unusual smell. His sleep pattern is normal. He prefers left hand more than right. And his activities for daily living, he's partially dependent. He can eat with spoon and he can indicate its toilet needs. On physical examination, anthropometry was normal. On examination, he had large unfolded ears, epicanthic fold, saddle gap, hypotonia, and reflexes were normal. His language and cognitive assessment showed expressive language delay equivalent to 14 to 16 months, and receptive language was around 18 to 20 months. Psychological evaluation using DAISY indicated a moderate delay in cognition and mild delay in socio-emotional and adaptive behavior, and CAS2 showed mild to moderate symptoms of autism. Suspecting Fragile X syndrome in view of moderate delay in cognition, autism spectrum disorder, and dysmorphism, Fragile X methylation test was performed after counseling, and the methylation status was positive. So parents were counseled about target treatment with metformin for Fragile X syndrome, but they were not willing to pursue this treatment. Hence, we suggested starting with speech therapy, occupational therapy, and teaching them with behavioral modification strategies. This included adopting appropriate parenting styles and providing explicit instructions to the child. After 2 months, Master J's parents came to our OPD and consented to start metformin as a targeted treatment for Fragile X syndrome. Child was brought to review after 1 month of starting metformin. Now he's attending Montessori and daycare along with speech therapy. He has shown improvement in behavior with reduced behavioral issues now. He now exhibits better sitting tolerance, improved learning abilities, and can identify alphabet-related objects. Additionally, he enjoys dancing to rhymes, socializes with other children, and communicates using gestures now. Ma'am, I'm done with the case. Can I move on with the discussion also now?
Yes.
Yes, ma'am. Discussion. Fragile X
Yes,
syndrome.
go.
Yes, ma'am.
Go,
Fragile
go.
X syndrome is the most common inherited cause of intellectual disability and the most common single gene mutation associated with autism spectrum disorder. While the role of developmental pediatrician or a pediatric neurologist is to primarily care for the children and adolescents with Fragile X syndrome, mutations in FMR1 gene can affect multiple generations, and it is the often a pediatrician who is the first to identify the mutation in the family. Previously, it was called Fragile X mental retardation protein. Now it has been changed since the mental retardation term is not acceptable. The term has been changed to Fragile X messenger ribonuclear protein. The incidence of Fragile X is 1 in 4,000 in males and 1 in 6,000 in females. But the incidence is slightly lower in Asian population. Since, as Sir said, we also did a study in our unit where we could, out of 50 cases we did, the only 3 were Fragile X positive. And the data is yet to be published. The average age of Fragile X diagnosis is 3 to 3.5 years. And the first concern
Priya,
usually.
can you, Priya, just hold on. Can you just stop here and stop sharing your screen for a moment? 1 minute. We just want to wind up with Dr. Vikram. He has to leave for his clinic. So just stop sharing because if I want him to give the final comments from his side, and there are certain questions left if he wants to answer, and the final take-home messages. Dr. Vikram, can you just see anything you want to answer specifically in there are new 4 questions in the Q&A and your final take-home messages, then we can continue the discussion to that. Other 5-10 minutes will take for the discussion, but you can leave after.
Sure. I think I tried to answer one question online. I think there were a couple of questions about treatment of younger kids. With it for anxiety, 2 points I would make is typically, I don't typically start. I haven't typically started kids under the age of 5 or 6 on an SSR on medication for anxiety. I think the youngest kid I ever saw treated was around age 3.5, and I had to be dragged to treating that kid. It was effective, but I had to be really persuaded. So as a general rule, we don't, mainly because functionally you're able to interrupt it behaviorally. You can pick up the child and move them. It changes when they hit 5 and they go to school. So typically, as I would say, I'm not talking about medications treatment in under 5-year-olds. If I am treating it, medication of choice for anxiety disorders, all kids is an SSRI. And so I would, that's where I would go with that. I wish I knew something more. I'm really interested. I'm sorry I have to leave now. I know there's a study in Alberta going on in metformin. I didn't realize that the results were that great. But that's really interesting. I don't know much about it though.
Yeah. Before leaving, take home messages, bus. That's all. And thank you so much for a wonderful, amazing take home messages.
Assume all kids with developmental disabilities, autism or not, will have psychiatric comorbidities. Assume that. And assume that the earlier, just like with autism, you identify them and you are able to intervene, you're going to reduce the complications and improve outcomes. That's the take-home message.
Thank you so much. Thank you so much for an amazing, amazing session. Thank you very much. Have a great day.
Thank you.
Thank you. We just short, going to be 10 minutes more for the rest of us. Can we just stay on for 10 minutes? Yeah, Priya, please continue. We'll find up in 10 minutes for the rest. And very brief on the discussion because we just talk about so that you know whether you can have the experts can have opinion. So review of literature, don't do, just say what happened to the child and then open it for the experts to talk. And then Dr. Uday Kumar can say some expert comments and then it'll be open to the.
Okay.
You can share your.
Yes. So I'll just give a brief talk alone, and then I'll go to the need for
the need. Yeah, not the literature.
Yes.
Yeah, what did you do for this?
For this child, we started on, since first, initially the parents didn't concern ma'am. Then after that, the child had more behavioral issues. So they came back to our OPD after 2 months and they said they're okay to start metformin now. After getting the concern from them, we started the child on metformin. And in the first month review, the parents were really happy. Though the child has been on therapy for a few more months before starting metformin. Now with metformin, the child started speaking words. He started identifying them as parents and calling them. He started using word gestures. He was able to say alphabet-related words. And his behavioral issues had come down. With metformin, his communication and has improved and behavioral issues have been improved now. So how metformin acts in Fragile X? Metformin has been shown to lower the matrix melanoprotein 9. In Fragile X syndrome, when the full mutation happens, the mRNA translation will not occur. So the MMP9 levels will be increased. When we use metformin, it lowers the MMP9 levels by reducing the eukaryote 4 levels, phosphorylation, which promotes the translation of a subset of mRNAs, including the matrix melanoprotein 9. So why we need to identify Fragile X early and treat is because treatment of children less than young, the Fragile X messenger ribonucleoprotein 1 gene, that will be producing something called FMRP, Fragile X messenger ribonucleoprotein. So this protein only, that mRNA translation occurs. When we identify below 6 years of age, the Fragile X syndrome occurs because of the absence of this FMRP protein. So when we identify before 6 years and start the treatment, we can reverse the upregulation of mTARC and MEK ERK pathways and lowers the elevated MMP9 levels so that the synaptic development is normal and the cognitive development. Most of the males, all the males with Fragile X syndrome will have moderate intellectual disability, and females, 1/3 will have ID, 1/3 will have LD, and certain females only will be identified after when the child is identified with Fragile X.
Thanks, Priya. Thanks, Priya. Actually, the experts have to leave because it's their date and they have clinic. Dr.
Yes.
Tuba has a clinic. She has to leave. So I will, Dr. Uday Kumar and Dr.
Yes, madam.
Ranjit
Madam,
also
I have
raise hand.
two-
Please, may come
Yes, madam.
Yeah.
I have two just curious questions, madam. How many children, what percentage of children with autism spectrum disorder, male child, are we going in for Fragile X screening generally in the population? And second question is, have people got experience in using metformin on a long-term basis in children with Fragile X syndrome in India? These two queries I'd like to get addressed.
Sure, I'll explain. Dr. Tuba will take over. Ranjit, you wanted to add something? You add fast because then Dr. Tuba will leave if she has to answer your question.
It was an excellent talk by Dr. Vikram. I just want to thank Dr. Priyadarshini and Dr. Uday Kumar for their excellent presentation.
Yeah.
And just one quick question to Dr. Priya. What is the obesity status? Was the child obese, or what is the anthropometric status of this child?
You're muted, Dr.
You're
Priya.
mute.
Sorry, sir. So this child was not obese, sir. The anthropometric measurements were normal. The weight of the child was between 10th to 25th centile, sir.
Thank you. Thank you. Dr. Tuba,
Well, yeah.
all yours. Opinion on this and your final take-home messages. Yeah. Our first opinion on this and the questions what Dr. Uday Kumar has said, and then take-home messages before we go to the other experts. I know you have to leave for the clinic here.
Yeah. Well, it's really important in this case, right?
Stop
'Cause
sharing.
we know-
Priya, stop sharing. Sorry. Sorry. I will
no
interrupt.
worries.
Yeah.
So this case is really important because we know Fragile X is one of the most single gene disorders that's associated with autism. One of the most common misthoughts out there is that Fragile X typically happens in males, whereas 50% of Fragile X kids do happen to be males that are associated with autism. There is 16% of females who do meet the criteria. The genetic testing comes back positive for Fragile X that is associated with autism. The second thing to remember is that even though we see more than 200 repeats of the CGG trinucleotide repeats that leads to the Fragile X diagnosis, we do know that repeats that are between 50 to 200 also increase the risk of autism, intellectual disability, global developmental delay, and also what we know as like ataxia and tremors that can highly be associated. And so it's important to even go into the history that are they uncles that were kind of clumsy, that had issues in school. Important to also think about fragile ataxia tremor syndrome. Any other questions that you all needed me to answer?
Tuba, there's one more question on role of surgery in if Fragile X, and somebody has asked secondary aphasia is a complex issue in ASD. I feel in such cases EEG will be useful to rule out LKS. Dr. Anis has asked this. Yeah.
So, we do know around 33% of kids with autism are at risk for epilepsy, right? And we also know, it differs on studies. Some studies say like 10% of kids with Fragile X are predisposed to epilepsy, and then if they have autism, that increases more. So anytime I see a child, even though they may be well established with me, I will always ask about staring spells and regression. Anytime you think about that, you have to get an EEG, right? And then the EEG doesn't show you answers, that's a routine, then you have to get the overnight EEG if the regression continues. So LKS is going to be in the differential, but it necessarily doesn't always have to be LKS, right? It could be other types of ESES, other types of seizures that are untreated that lead to developmental regression. So it's always important to keep that at the back of your mind. Any other
questions? Experience in metformin? Metformin, have you
Yeah, so it's really interesting, right? We have like all these studies and there's this shining light of hope, like we have toffelinide with the Rett syndrome. So metformin, a lot of the kids with Fragile X end up having increased an appetite, right? And so I personally have not seen in my patient population that escalation in language and vocabulary. And even when we look at studies, we don't see this outburst that suddenly happens from metformin intake. So I do believe it may be a combination of good pharmaceutical agents in combination with ABA therapy and that early diagnosis. I mean, for the last 10 years, there were studies with Buspar and that increasing speech, and it was found to be effective in kids that were as young as 2 years of age. And so then that became kind of a way of adding that even in kids where anxiety wasn't thought to play a role. And then that kind of simmered down. So it really is about seeing those long-term studies, right? Like if metformin is truly a strong cause of language development, then it should continue with that vocabulary intake. The child shouldn't just plateau 1 year after taking the metformin. So yeah, we have good studies with SSRIs and some studies with metformin about language development, but then when you look at the longitudinal studies, there wasn't that strong effect on language development.
Thank you so
Thank
much.
you,
Your
Dr.
take-home
Tibu.
messages before you leave. Sorry, Dr. Uday Ekman, she has to leave.
Thank
So
you.
before that, I'm asking her
Yes,
to give
yes.
take-home messages. Yeah. Thank you. Yeah, Dr. Tuba.
So in terms of comorbidities, right, the most concerning comorbidity is that of aggression, right? Because when we think about some of the other comorbidities, they do affect the child and how they thrive at home and at school, but aggression is something that can harm them, their family members, and along with others if they're going down the street. So they are FDA approved agents that are dopamine targeted agents known as Abilify, Epiprazole, and Risperidone. And they're FDA approved in like 5 to 6 years of age. And obviously if the aggression is really severe, we can just, sometimes time is not on our side to wait for a few months with applied behavioral analysis. So it's really important for the child's safety, as long as they're tolerating the medications with minimal and hopefully no side effects, that pharmaceutical agents can sometimes be life-changing and very important for safety. So therapies and always reevaluating the child, and in certain cases, important FDA-approved medications are important.
Thank you so much. Thank you so much for joining. Have a
Yeah,
great
thank you
day.
so much for
Yeah, thank
having
you.
me. Take care.
Thanks.
Bye.
Thank you. Dr. Uday, you wanted to say something before I request
Madam, I just
our
want
friends
to have
from
the
Turkey?
opinion. Yeah, I just want to have the opinion of people on the usage of metformin, like because we are now don't know like whether we are going to continue metformin on the long-term basis for 6 years.
Yes, sir. We also don't have any personal experience on using metformin in autism. We are also, metformin is a drug which is being repurposed for many things. We are also trying to use it for as a difficult to treat epilepsies. Also, we're trying to see along with ketogenic diet therapy. So it is a lot of potential. We'll have to keep waiting and watching. That's what she was saying, that they've not seen that much improvement in whichever patients they have given. Thank you so much for presenting the case, and we really have looking forward to more collaborations. Now I go to Turkey before I come closer to Pakistan, which is closer to India. And so please, Dr. Sezen, and I think Dr. Hassan is also there. Any comments from your side? And then we have Dr. Tipu and Dr. Iram Javed. Dr. Hassan is left. Then Dr. Sezen, yours.
Yeah.
Your take-home messages and final. Yeah.
My take-home messages, I want to say that autism has multiple comorbidities, developmental comorbidities, neurologic comorbidities, and psychiatric comorbidities. Defining and treating the comorbidities is very important and life-changing, as Dr. Vikram said. All of us should be aware of these comorbidities, to my opinion. And what can I say? overlapping symptoms are important, to my opinion, from the Dr. Victim's presentation. ADHD, ASD, anxiety disorders. We should differential diagnosis we should be very careful for differentiate the diagnosis and pharmacological agents are very helpful for us, as Dr. Tuba said. I want to underline these issues from my opinion.
Thank you. I think Dr. Hassan is logged off. I think now we'll request Dr. Iram and Dr. Tipu Sultan to give their opinion from Pakistan. Thank you so much, Sen.
Thank you, Shifali, for inviting us and giving the opportunity. First, I would like to have opinion and the comments from my younger colleague, Iram, from Children's Hospital, Faisalabad. Iram, can you hear me? Yeah.
Sir, I can hear you. Good evening, sir.
Please give comment, Iram.
Iram, your final comments. We heard your comments in between, but now final comments.
Iram,
so
can you please on your camera as well and the mic?
So, autism spectrum disorder really a challenge not only for for the clinicians, but also for the parents who are dealing with these kids. As far as the pharmacological management is concerned, in my experience, for aggression is the most difficult part of these comorbidities. And my experience with risperidone is good. And along with that, in older children, more than 5 years, aripiprazole has also good role in terms of aggression management. And over to Professor Tipu Sultan, and we would like to know his experience.
Thank you, Iram, thank you, Iram. As said by Shifali, we are the final speaker in this webinar. So I think summing up everything, first of all, I'd like to congratulate Shivali for highlighting perhaps a very important topic and the case series from different corners of the region. Being a pediatric neurologist, though we are not considered as an expert for treating children with autism or ADHD or all sort of neurodevelopmental disorders. However, over the past 20 years, since I into the child neurology practice, what I have observed, this this subset of neurodevelopmental disorder within pediatric neurology is it's a silent pandemic. Because what I have observed, the number of patients we see at Lahore Children's Hospital 10, 15, 20 years back is perhaps 10 times more if we consider the number and compare them with the true pure neurological disorder. I mean, I'm talking about children with purely epilepsy or children with pure neuromuscular disorder and children who have either epilepsy or some sort of developmental delay along with many of the neurodevelopmental disorders. First of all, I think this is the time we should not only focus some sort of prevention apart from the treatment, we should give some scientific evidence for the, I mean, being the pediatric neurologist and the scientist, we should focus on to find the underlying etiologies of these huge number of developmental or neurodevelopmental disorders. In my experience, the common etiologies in this region is genetics, followed by infections and then subsequently maybe injudicious use of too many medication, either during pregnancy or even maybe before that, particularly among the moms. I think this is the time we should focus and work on the preventive aspect of this big group. As far as the management is concerned, I am totally agree with my fellow colleagues regarding the use of these relatively older version of antipsychotic drugs as well as the newer version. Being in the field for past 20 years, many years back, I was the one who started with this risperidone, and many of my colleagues in Pakistan were not very receptive, because at that time, I'm talking about 07, 08, when I just came back from Glasgow and started practicing child neurology in Lahore Children's Hospital. At that time, risperidone was not an FDA-approved drug. So my fellow colleagues in Pakistan, they were not very receptive for even trihexyphenidyl for the control of drooling in all these children, and risperidone. Subsequently, with the advent of atomoxetine and approval of risperidone by FDA, these two were widely practiced. However, in the recent past, as mentioned by Iram, aripiprazole and some of the newer drugs were into the practice with a reasonably good response. To sum up, the core management, fundamental management pillars are rehabilitation, and when and where the indication and the situation allows, this pharmacological therapy, but not least in the recent experience of this ketogenic diet and some of the dietary modification, what I have observed is restriction in carbohydrates diet have a significant impact, at least in my personal experience. Putting together this dietary modification, this behavioral modification, as well as when and where indicated, is the pharmacological therapy. This is my personal experience and suggestion to my colleagues, and open for discussion as well. Over to Shifa.
Dr. Mary, before you make the final comment, Dr. Veena Kalra, ma'am, you couldn't unmute earlier. I want you to tell about your 40 years experience.
Yeah.
Dr.
Double
Kalra? Yeah. Dr. Veena Kalra, can you unmute yourself, madam? Asmita, can you unmute madam in case she has a problem? Asmita?
Yes, ma'am.
Unmute madam.
Hello.
Yes, ma'am, we can hear you.
Hello. Yeah. Can you hear me? Okay. Hello. It's been a very, very wonderful evening. I think the talk by Dr. Dua was really outstanding. I think he gave an idea, beautiful idea, as to how to look at autism, not
Your voice is breaking.
in childhood, but as a bit of morbidity. I think that
Ma'am, you are not audible clearly. Can you can maybe the connectivity is poor. You can switch off the video and you can speak, ma'am.
Can you hear me?
Hear you. Now we can hear you. Yeah. We could hear you. I think.
Hello.
Yes, ma'am. We can hear you.
Hello. Can you hear me?
Yeah. You're audible, ma'am. Now please repeat it, ma'am. Yeah. We could not hear you earlier properly.
Okay. Yeah. It was a very
Sound is still break. We can't hear it.
Ma'am, you're muted.
Very beautifully was something that I've always felt. No, I'm not. Can you can't hear me? I'm not muted from this end.
You're audible,
From
ma'am,
my
right
end,
now.
I'm
Please
not
go.
muted.
Ma'am, you are fine now. You please speak, ma'am. You're fine. You're
Okay.
fine. You can be heard. Yeah. Yeah.
So I think what we have to really, the way I look at autism is that you have to really imagine and keep the spectrum of comorbidities can be missed if we are not alert to picking up these comorbidities till they become more sinister, more outstanding, and have become a problem for the family, the child, and the physician. So therefore, we must keep our mind open to picking up associated comorbidities like maybe depression, anxiety, hyperactivity, all this very early. And I think in terms of treatment, we have to realize that the management involves not only a team, but involves a variety of to address the problems of these children. Drugs, therapies, educating the family, putting them into good social environments have all to be started simultaneously. It's not one after another. It depends on what the child is doing. Is quite time may not always be productive. To fast track the result of therapies, it helps the family, it helps the child to we causing harm is possibility. We are looking at those possibilities, and one should not shy away from using pharmacotherapy as and when it's required. It may be early in some children, and I think we must be absolutely careful about that. In my practice, I found that using them when therapies alone have not worked, to use add-on therapies significantly improves the result. The other thing is that regarding using the kind of doses for good result, and these drugs are to take effect. Therefore, these on a basis for these children. All those really expedite. Remember that generally the mother has come with a new problem, and we must be aware and take care to identify the new problem so that that can be addressed. That may be in terms of either changing environment of the child, or if the child is revolting to something, or if the child even can have some may happen as a result of drug reactions. So we have to be very, very careful. But what I really find is that somebody made a comment that the therapists really tell the patients to stop the drugs. And I'm very averse to this. I think the doctor should take charge of the drug. The therapist can inform the doctor, but on is not correct. I think it has to be done in conjunction. If they bring the choice of aripiprazole and risperidone, risperidone generally use risperidone in a lot of these children. Sleep disorders, and those have to be fixed by all other measures. Improving their sleep considerably improves their outcome. Regarding epilepsy, I think we have to be careful of avoiding certain drugs in children who are having under the spectrum and have comorbidities. And I think we have to be absolutely careful. Oxcarbazine is not a preferred drug. Phenobarb not a preferred drug. Clobazam not a preferred drug. So we have to really make good choices in using the anti-epileptics, of which I think sodium valproate, lamotrigine are generally good. Levera also can cause behavior disturbances in children who are under the spectrum. The last thing I would like to say is, which I really like by Dr. Dua's presentation, is that we must keep that the same child is going to undergo different kinds of diagnosis at various points in life. And we must know that these are all part of the whole spectrum, the lifestyle, the life and age spectrum of this disorder. And we must be absolutely aware to identify them. The other thing is that many a times there are other family members in the family who have lesser degrees of symptoms and have been missed. So I think it's very, very important to ask them. This also helps us to identify whether the autism disorder in a particular child has a familial or a genetic basis, if we find multiple members in the family. So therefore, it's an important question to do as part of the complete workup. Regarding schooling, I think we in our country are not having enough support from the schools for these children. And I think that's something we should work on, whether there's a simultaneous stream that's created, or the teachers can be trained better, or the parents can be asked to function as shadow teachers. So I think this is a part that's particularly lacking. And for parents to manage a day in the life of an autistic child is a real challenge, and we must counsel them on these. So I think I would end these comments, Shefali, and all the group. Congratulations for a very beautiful talk by the experts and the speakers.
Thank you, ma'am. Dr. Mary, thank you so much, ma'am. Always a guiding force, and we have to, I'll ask Dr. Mary to give her concluding remarks, and then Mahesh, and then I will just wind up. Mary?
The deliberations today were perfect and complete. I think what brings the parents to tears in the end is when the child becomes an adolescent and he starts showing sexual overtures, when voyeurism and open masturbation and all happen. So actually, all of us should try to find out a way to prevent this, perhaps by educating the child or the parent or something. Some algorithm has to come in place. So this is when the parents really go into tears. Okay, thank you.
Absolutely. Thank you, Dr. Mary. Thank you. Mahesh? Secretary
Yes, ma'am.
of AOC in India, sir.
That is really a very good talk and discussion, ma'am. Like as what Dr. Neelakanta told, I also believe that it has to be both with pharmacotherapy and the behavior therapy. So I always follow this combination of both pharmacotherapy and behavior therapy that gives the best results rather than doing only behavior therapy alone. We do only behavior therapy, takes a very long time for the response. Sometimes parents give up on the therapy part. So with medication, we get quick results. So I usually use a combination of both risperidone along with psychotherapy and behavior therapy. Otherwise, it's a very wonderful webinar and very good discussion.
Thank you so much. And I think it is, as everybody is saying, we have to understand that he has to be holistically seen. Comorbidities are there in 80%, like we have seen, and even 1/4 of them had more than one comorbidity. Sleep gets very much missed. And, if you, so all those things, we don't talk about sleep hygiene. We don't, there's so many issues. The parents have to see it as a family approach, and it should not be like in India. I don't know about other countries, is always pushed on to the mother. They end up having depression in 3/4, as I shared. So I think we have to, but as a primary care, we are the pediatric neurologists who are looking after, we have to explain the whole thing in stages to the family, do have family counseling, and they should be aware of what is expected as the child grows. And, they should be having coping strategies. And obviously the rational use of the medications along with the other interventions are the mainstay which has to be there. It should not be waiting and watching, and obviously parents also should understand that they are not addictive, and when they're advised, they should go around and taking about it. I thank everybody. I thank our friends from across the globe and everybody who has joined. Next week we are going to have a very amazing session again of how to assess behavior in these children, because we many times, we start, now we have understood holistically to be seen, but then we keep adding, we find some behavior issues, we keep adding in medications. So we add one, we add the other one. The next week we're going to have another colleague from Canada who will be talking about how do we assess the behavior and what parameters to see, so that we understand the behavior and use the we use the correct kind of medications. So that becomes a very important situation which is there. So that's why so thank you so much, and everyone, and we join in next time again, so as to understand autism is important. Indeed, it is becoming a global epidemic with the 1 in 36 according to CTSET Lansa of last year, and in India our figures were 1 in 89, and the data which was taken, that was we had collected the data back in 2011. So we can understand that there is so much happening in our country as well, so it is important to see. So I think we will have to understand, and we have lots and lots to do and together. And as you rightly said, Dr. Javed, we should be doing, and I think under with our Center of Excellence and Advanced Research in Neurodevelopmental Disorders, AOS in India and AOCNA, we will ensure that we bring a lot of education packages for at least South countries, and we'll have other high resource country people also pitch in so that we understand both sides. It's not so, I think that's how, our friends from Turkey and our friends from US added. So it is important, and that's why how conceptualized, I mean, what we have done right now is I always want people from different resource settings to discuss the things, because we may not be able to look at it. We will understand more, and we will be able to get out more solutions as the way we go on. But I see that we are neighbors and we are having similar problems, and so we have to move forward. And I think holistic evaluation remains a mainstay. And somebody did ask about how do we know about therapy centers. You need to know the qualification of the people who are giving you therapies, and you have to be with the child. It should not be in a closed door scenario. So it is something important that we have to understand. Thank you so much, and have a great day and good night.
Thank you, madam, for the opportunity.
Thank you. Bye. Bye.